Okay, so I'm Dr. Ravi Serenal. I'm here with Dr. Sean Lewis, Orthopedic Surgeon. And we're here to talk about knee arthritis. So let's talk a bit about knee arthritis. What is the cause of knee arthritis? Who normally gets it? And what are the symptoms?
Knee arthritis is common in elderly or people who are getting older. Is what osteoarthritis really is wear of the cartilage cap that covers the bone. So this usually comes after a long period of time. Those who used to play a lot of sports before, those who used to do a lot of hard work before, and those with manual labor. It's basically wear and tear of the knee. So those who are a bit overweight as well tend to make the condition a bit worse. The symptoms of osteoarthritis, it usually affects those that are over 40 or 45, will be pain, swelling, some stiffness within the morning, and stiffness usually gets better in the day when you walk, and it gets a bit more stiff at the end of the day. You might also have a bit of swelling as well, which is fluid within the knee, and that fluid is basically an inflammation, which is inflammatory fluid from the bones rubbing on the bones with loss of the cartilage.
Okay, now say you mentioned those used to play sports. Okay, so what is the mechanism by which an athlete may develop knee arthritis at an earlier age than the average person?
Right. Those who play high impact sports, I mean, a lot of bending, twisting and turning. So it's high in those who play football and basketball. Also rugby, which is not very common in Trinidad, but could cause a lot of injuries as well. Those who had previous injuries to the knee, whether it be fractures or injuries to what they call the meniscus, which are some cushions between the two bones in the knee to protect it, tend to develop arthritis later on in life as well.
Okay, so also too as well, I guess when a person has an injury and it heals, what we may get is some altered mechanics of the knee joint.
That is true.
Right?
Yeah, that is right.
And then
that is where physiotherapy comes into play. A lot of times with sports players, they do something called prehab, which the physiotherapists help to avoid injuries, certain injuries, which may cause problems later on in life.
Okay, all right. So you mentioned prehabilitation. Now, I really want you to touch on prehabilitation because it seems that everybody is ready to treat the condition after the condition has occurred.
Yes.
And when there are symptoms and when there's pain, when there's a reduced quality of life. But yes, I think prehabilitation, or I guess that's what is called preparation,
yes,
or strengthening the body. So touch a bit about prehabilitation as it applies to athletes as well as the non-athlete.
Okay. Prehabilitation is very important. I mean, it's widely used within the developed countries, be it the US and the UK, especially those athletes who perform in those higher divisions. Also those who do manual labor and who are prone to damage, especially those who are accustomed to getting damaged frequently. What you lose is a bit of balance with each injury, and it makes the chance of getting injured after very high. So physiotherapy will much help in those cases, whether it be in sports or manual labor.
Okay, all right. Now, in terms of the symptoms, so let's talk a bit about the symptoms. A lot of people will have pain in the knee. Now, not all knee pain is knee arthritis. I mean, there are many structures there with the knee. You have the cartilage, you have the ligaments, you have the muscles. So knee pain can be due to cartilage wear and tear, ligaments strain, weak muscles. So what is really specific about knee arthritis as opposed to a ligamentous or a muscular injury?
Right. With muscular injury or muscle pain, there usually be an inciting event. Also, you get pain with movement in a specific spot. In terms of the ligament injuries, they will have a history of trauma. Those who have a history of injury, and they will have instability in the knee, feeling like it wants to give away. They will also have problems going up and down the stairs, and that too will cause a lot of swelling. To differentiate between injury and osteoarthritis, I mean, It might be a bit difficult without that type of inciting event, especially those who are elderly. In the younger cases, those less than 40, you wouldn't be thinking osteoarthritis off the top of your head. With knee pain and swelling, you'll be thinking of something called meniscal injury, which is the little cartilage disc between the two bones that usually protects and help distribute the pressure within the knee.
Okay, all right. Now, there's a saying, don't know how true it is, but a lot of people say, a lot of people with knee arthritis say when the weather sets up and it's time to rain, that the knee pain comes on. Is there any real link between the weather and knee pain and knee arthritis?
That's a very interesting question, but always I hear that. All patients who are older, when the weather sets up to rain, they know. But I haven't heard anything, documented on why that happens. But I know it's a very common thing.
Okay, all right, no problem. Now let's talk a bit about knee supplementation. Let's start small with the management and let's move up to the more intense types of management for knee arthritis.
Okay.
A lot of people, they talk about knee supplements, the glucosamine, the chondroitin, the MSM, the turmeric, the shark cartilage, the shellfish. What role do these type of supplements play in managing knee arthritis?
Okay. Well, we reached it, but let's start with the basics first. In terms of managing knee arthritis, it's all across what decreases the load across the joint. So if you're thinking about a truck, what will wear that tire less? So less load on the knee, so weight loss. Also, what will decrease the load across the knee is some soft shoes. And those with more advanced cases, a walking stick will help to offload the weight on the knee as well. In terms of the treatment and management, the supplements, yes, there are supplements. I know there are chondroitin sulfate and those things. But as far as I'm aware, in terms of my studies, there's no evidence to support that. But it is available, and I don't know how much it offers to the management of knee arthritis. Everybody in Trinidad know ginger and turmeric. And we do know ginger and turmeric are anti-inflammatories. So it can help with some of the pain in the knee.
Okay, so the supplements may help with the knee arthritis management in terms of quelling inflammation and pain, not necessarily in rebuilding cartilage.
No, so far up to date, there's nothing that could rebuild cartilage in the knee.
Okay.
Small cartilage defects, you can treat by putting stem cells there, but it's not available in Trinidad right now. Okay. The other management of the knee arthritis, what could help, like a stem cell injection, those with small areas of cartilage loss, something called PRPs, which are platelet-rich plasma. Basically, that is taking your own blood, putting it in a centrifuge, and taking out the platelets, which have the healing capacity, and injecting that into your knee. What it does is it kind of try to build back the cartilage, but as of date, there's no real evidence to show how much it does, but it does offer some benefit in the short-term trial, because it is relatively new. Okay. A relatively new treatment.
Okay, all right. Now you mentioned offloading the knee mechanically, losing weight, soft shoes, using a stick. What about knee braces in terms of helping with the symptoms of knee arthritis?
When you have advanced cases of arthritis, you start to wear down one portion of the knee, whether it be the inner part or the outer part. And it makes the knee feel a bit unstable because there is bone loss in either side of the knee. So your knee will be moving to and fro, whether it be from this side to that side. In those cases, the knee brace or the knee bands could help and could offer some additional support. The knee band, in those with a lot of swelling, could help to not let the swelling get worse at the end of the day. But the knee braces usually reserved for those with advanced cases. What I want to stress is prolonged use of that knee band or knee brace shouldn't be encouraged because you become dependent on it and you lose the muscle support that your knee really needs. Right. Yeah, but if you need to walk for short periods or long periods, definitely you could wear it during the day. Okay.
Right, so in terms of advice, again, it comes with the whole use it or lose it principle.
Yeah.
If you use the knee band too much, your muscles don't have as much work to do.
Very
and while in the short term you get some relief, in the long term, it could be detrimental to you.
Exactly.
Okay.
Exactly.
Right, so let's talk a bit about a bit more about physiotherapy in the management of knee arthritis. So, when I say physiotherapy, yes, your traditional physiotherapy, and also maybe massage therapy in terms of helping with the knee arthritis.
Okay. With knee arthritis, well, as with any other pain within the body, when a joint has a lot of pain, the muscles around the joint spasm. And that's a general protective measure that your body, allows to help with the pain. But they usually cause a lot of spasm and pain at the end of the day, not within the knee, but also the muscles. For those with muscular pain, because of the spasms, definitely massage could help temporarily. The physiotherapy is more of a long-term benefit. Even before, or even if you have to have surgery, we always recommend physiotherapy. I guess we haven't reached the surgery just yet, but physiotherapy could prevent the osteoarthritis from progressing very quickly. So it allows you to have a bit more pain-free time before it progresses to that end-stage arthritis, what they call.
Okay, all right. Right, so we talk about physiotherapy, massage, the support. Now let's get a bit more invasive, right? So let's move to steroid injections. What is the role of steroid injection in helping with knee arthritis? Who can take it? Who can't take it? Let's walk us through what goes on here.
Yeah, steroid was basically made for inflammation. The only thing steroid does is stops the inflammation for a period of time. Those with pain and swelling is yes because the bone rubbing on the other bone, but that creates an inflammatory response. And that inflammatory response gets the knee swollen and causes a lot of pain in there. The steroid gets rid of that inflammation and it gives you a pain-free period for about 3 to 6 months. But the amount of time how the steroids work for people depends on how bad the arthritis has reached. But it does offer a period of no pain, so you can do proper physiotherapy. Because I also always tell patients the steroid is just temporary, but with that pain-free portion is for you to work on your physiotherapy harder. You know, because physiotherapy always hurts at the beginning, always does, in that strengthening phase. And you always have to explain that's a normal part of how the therapy works. But that steroid definitely helps with that period.
Okay, right.
But it's more for people with a lot of pain. I wouldn't recommend with mild pain to be taking steroids. Also, when if you have to take steroid injection, you shouldn't take it within 3 months. So you should only do it 3 to 4 months apart, because steroids could cause the bone to get weak if you over inject into the knee. Also, those with diabetes, it could cause an increase in the sugar levels. So it's important for those having steroid injections to tell your doctor that if you're diabetic, so you could monitor your sugar very closely within the next 2 weeks of that injection.
Right. So with diabetic, steroid is not an absolute contraindication.
No.
All right, so diabetics can receive steroid, but the person must be on point with their sugar control.
Yes, that's true.
Okay, all right, no problem. Right, so we talked about steroids there. Now let's move up to our next level, I guess, if you want to call it that. Let's talk about PRP with knee arthritis. Again, let's delve a bit more.
Okay, PRP, what it means is platelet-rich plasma. So plasma is like a body fluid within the veins, on the arteries, and the platelets are those things that heal when you have a cut. They form the clots. Not only does the platelet form the clots, it also has a lot of healing capacity, or that stem cell ability, what they call. So it has a lot of healing potential. So, I mean, the use of this PRP is fairly recent within the medical field. Not really medical, but orthopedic field. Basically about 20, 30 years. So far, it has been showing good results. We don't know very much now how much benefits it offers, but it has been doing very well within the short term, meaning it helps patients with short-term relief. It's more reserved for those with a mild to moderate arthritis. Those with severe arthritis tend not to get any relief with those PRPs. What it is about is taking your blood, spinning it down in a centrifuge, and extracting the platelets within that sample taken. Now that will be injected right to the area where that is needed, in this case the knee. And what it does theoretically, meaning in theory, is it allows cartilage to build again and to heal any tears within what we call the meniscus. As I said again, is cartilage that protects both of the bones in the knee? Is it in between the two bones?
Okay. Now you mentioned the PRP is like it has a stem cell-like effect, but there is a difference between actual stem cells and PRP.
Definitely, there is a difference, yeah.
Okay, so let's touch a little bit now about stem cells specifically for knee arthritis.
Yeah. Right now, it's still in the developmental stage. It's so far by the American Academy of Orthopedic Surgeons and the European Academy is not recommended for severe arthritis and moderate widespread arthritis. It's only recommended for those with small, isolated small, meaning 1 or 2 cartilage defects, not for those with a lot of cartilage loss.
Okay, so we spoke about steroid, stem cells, PRP. Now let's talk a little bit about viscosupplementation.
All right. Now viscosupplementation as well could benefit. I mean, these injections offer some relief, so you could do some therapy, and it also tries to delay the end stage, meaning surgery. So you want people mostly try to delay surgery as much as possible, and I agree, because the knee replacement itself has a limited life of 15 years. Okay. So we don't recommend getting a knee replacement before the age of 50 or 55, unless it's extremely severe. The viscosupplementation is another option other than the steroid and the PRP. Now what that is a high concentration of hyaluronic acid and proteoglycans. I know there's a lot of big words, but what it really is what your knee fluid was, or what your knee fluid is composed of. So it supplements that back into the knee. In theory, it's supposed to allow the bones to be a little bit apart and to allow smooth motion, a frictionless kind of motion between the two bones. Again, it doesn't work very well in severe arthritis, and it's still within its stages where we do not show the exact benefit, but definitely it benefits some patients, and it is an option before thinking about surgery.
Okay, so now what I tell people, how I tend to distinguish the steroid and the viscosupplementation with patients, and you can correct me if I'm wrong here. I say with the steroid, you're more really bringing the inflammation down for pain control.
Right, that's right.
And there's no attempt to actually fix the problem. There's more to control the pain. But with the viscosupplementation, there is an actual mechanical support given to the knee. So is there some sort of an attempt to quote-unquote repair in that sense? Is that a bit of a good comparison or a bit of a stretch? What do you call that?
It may be a bit of a stretch. It's not so much. It wouldn't heal anything inside there. Okay. But what it does, as you're right, it is a kind of mechanical force that kind of brings the bone apart. That allows it to move a bit.
Okay.
All right. Okay. But it is a good option for those with arthritis and have exhausted all the other options. And before thinking about surgery or anything like that, it is a good option to try.
Okay. Okay, now we recently did a video with a patient receiving the viscosupplementation, and in the video it shows we also put in steroid after. So explain to the audience why it is you would want to, if viscosupplementation is quote-unquote a level up from the steroid, why are we still giving steroid with the viscosupplementation? Why is that an option?
Viscosupplementation doesn't work immediately. It takes a while before you see some results. Most of the times they say within a month to 6 weeks, you start to get a better relief. The steroid is more for that immediate relief of pain. Usually with the steroid, you get relief of the pain after 3 days, versus the viscosupplements, which could last 1 to 2 months before you get some relief.
Okay.
So it's more of to offset the pain, to make the patient a bit more comfortable until the viscosupplementation acts.
Okay, so the steroid basically gives that coverage for when the viscosupplementation isn't working.
Yeah.
When the steroid wears off, then the viscosupplementation sort of quote-unquote kicks in. That's how basically it's supposed to work.
Yeah.
Okay, all right, no problem. And okay, so we've spoken about the viscosupplement. Now, some people, I had someone on the phone who was asking, they want the viscosupplementation, but they don't want any steroid. In a case like that, how would we approach it? We will tell the person, still expect some pain for a couple of weeks before the viscosupplementation really begins to
definitely
have effect.
Okay. I would tell patients that you don't always have to take these steroids. It is up to you, and the viscosupplementation will help most of the times. You just need to give it a little more time.
Okay.
You know, some people expect immediate results from it, but it doesn't work like that. It takes a little while before you get that relief.
Right.
I have some patients who get relief only for 6 months with the supplementation versus some who had relief for about 2 to 3 years. So it is not a fixed science or fixed benefit period. It varies from person to person and the stage of arthritis.
Right. So now, in these cases here with steroid, with PRP, possibly stem cells, with visco supplementation. So while these things are given, therapy is still recommended.
Physiotherapy is always recommended.
Always recommended to maximize on the benefits.
Exactly,
Of
yes.
these. Okay. So it is not a matter of these being a replacement for physiotherapy.
No.
But rather working in conjunction with the
Definitely.
physiotherapy.
Physiotherapy is probably more important than the injection. The only problem is therapy hurts, as we said. So it kind of helps to balance that pain and allows you to progress faster in physiotherapy or better.
Okay. All right. Okay, now let's see all else fields now, and now we are moving to knee replacement. So let's start touching on knee replacement, talk about different types, tell us benefits, who can do it, who can't do it, what is somebody to expect when they do a knee replacement?
Right. I mean, with all surgeries, there are risks, and that is classed as a major surgery. But I mean, in modern times and with the progress in medicine, it's become safer to a point. I mean, anybody who has to do a knee replacement has to see a medical doctor if they have any medical problems to get clearance for surgery. I mean, those injections were only a temporary benefit, but the only way to get rid of that pain fully, for those who are in a lot of pain, the knee replacement is the best option. What the knee replacement does, because of the osteoarthritis, there's bone rubbing on the bone. There's no smooth surface, meaning there's always friction. There will always be pain. What the knee replacement does is it takes away that bone-to-bone contact, and it places a metal in both sides of the bone and a plastic thing in between. So it allows it to move very smoothly, and that takes away the pain with the osteoarthritis. The risks of knee replacement, bleeding and infection. Infection being the most major risk with that knee replacement. But the knee replacements have been tried and trialed for almost, I don't even know if it's a century just yet, but it's been long within the years, and it has proved to be the best option for full relief for knee osteoarthritis.
All right. Now, tell us about a person who has osteoporosis and is reduced bone density. In a case like this, from what I know, the bone must be of a certain density for the actual knee replacement to hold. Because as far as I think part of it goes inside the bone, like a nail to hold in there.
Yeah, with the nailed implants, meaning the stems within the bone, those are more for advanced cases, and those with like fractures of a knee replacement. Generally, we don't use that initially. Okay. We cement these implants within the bone itself, and it usually holds. In terms of osteoporosis, if it's a severe osteoporosis, meaning postmenopausal and the bone density is very low, you will first need to build that bone density back up, because it could cause fractures within the operation, and it could cause loosening of the implant later on. But I mean, if you visit your orthopedic surgeon, he will always do that formal assessment, being in x-rays, and he will notice, and he will send you for whether it be supplements or something to build back the bone.
Okay. Yeah. All right, so now we have the knee replacement. So talk to us about the lifespan of a knee replacement. From what age beyond is the knee replacement appropriate?
All right. I mean, generally reserve knee replacement for those over 55 and in some cases over 50, because it does have a finite life, meaning it does have a temporary lifespan. Lifespan now is about 20 years, which I find is a lot. I mean, if you have a knee replacement at the age 55, you live up to 75 with that implant before it causes any wear of the plastic surface. If there's wear and you start to get a lot of pain after, you will have to do a revision in knee replacement. But as later down in stages, what the knee replacement does is only to stop the pain. You cannot do any manual labor or running with it. You can do walking, cycling, swimming, stuff like that. Because like all mechanical surfaces, if you overuse it, or you put a lot of load through it, it will wear faster.
Right, right.
Yeah.
Okay, I guess that's because I guess the natural knee has a greater lifespan because
Yeah, definitely.
there's actually it repairs itself when you sleep.
Yes, yes.
The implant doesn't repair itself.
No.
It just wears, and when it wears,
It goes,
stays
yeah.
there. Okay, I get you. All right. So, okay, a person may ask, well, why does the knee, why does bone, natural bone, has a longer lifespan than metal? Well, the answer is basically with the natural knee, there is repair every night of the surface.
Yeah, I mean, the metal doesn't wear per se, it's the plastic
Okay.
in between, because if you put metal on metal, it will abrade each other, so it will be worse. So the plastic is what really wears.
Okay.
And that's caused a lot of problems within the years. But there has progressed in terms of manufacturing of that plastic interface,
Yeah.
and usually lasts about 20 to 25 years.
Okay. And that metal is pretty strong. That's made of titanium. It's a titanium alloy.
It's an alloy of titanium and cobalt chromium. So
Okay.
it's a very strong. It is stronger than bone,
Okay.
the metal itself.
Yeah.
But the plastic is what is the problem.
Okay. All right. In terms of range of motion of the knee joint, so let's say before when the person was young, you had full range of motion of the knee joint. You put in the knee replacement. Are they to expect what percent reduction in knee range of motion would a person possibly expect?
You should get no reduction
Wow.
in that range of motion. Actually, in those with very bad arthritis and have decreased motion, meaning they could only extend and flex to about, say, 70, 80 degrees and can't get back all the way. And the replacement could fix that.
Okay.
Yeah, so you allow a greater range of motion with some of these implants.
Yeah.
I mean, via the assessment that the orthopedic doctor make on you, he will see which implant is best for you to get that full range of motion that you need.
Okay.
Some people with advanced arthritis have deformities of the limb, whether the leg goes this way, what some people call bandy leg, and knock knees.
Right.
The replacement could correct that as well.
Okay. All right.
Yeah.
So in terms once again, the role of physiotherapy post-surgery. That
Physiotherapy pre and post surgery is very, very important. I don't think anyone will operate on you, meaning in a knee replacement, until you have surgery before and after.
in physiotherapy.
Physiotherapy
Right.
before surgery and physiotherapy after surgery, because you'll be very dependent on your muscles after. So that prehab, what we spoke about, is very important for knee replacement.
Right. Okay.
Yeah?
Good.
And also the physiotherapist help you to get back onto your feet after.
Okay.
And you could walk immediately after surgery.
Oh, okay. Wow.
Yeah.
Okay. Okay. Now tell us about one of the complications. Infection. Something the knee joint or the knee replacement can become infected. What sort of percent of infection rate we're looking at here, and and how is it managed? How would you catch it early and to save the knee? How you?
In terms of the infection initially, what they call acute infections, the rate is less than 2%. You could also get it within your whole lifespan of having that foreign body in your system. So you could get it from any infection within the blood. Could come and settle within the foreign bodies. And they have found that with dental procedures, it could cause bacteria to go into the blood and cause infection within the knee as well. So it's things you just need to be wary about when you have a knee replacement. The orthopedic surgeon will tell you what to look out for, what procedures or invasive procedures you need to be wary about, and to just cover with antibiotics if need be.
Right. Okay.
Yeah.
Right. Okay. So I think it was very enlightening in terms of knee arthritis. So what we did, we covered the basics of management, from supplementation to the physiotherapy, all the way from the steroid to PRP to viscosupplementation, all the way up to knee replacement surgery. So I hope our audience found this to be very helpful. And if you have any questions, you can contact Progressive Health Services Company Limited in Chincuna Road, Cunupia, where you can see our orthopedic surgeon by appointment. So great. So ask us any questions you may have, and we will be happy to help. That's great. That's good.
Thank you.